Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Germán Ramirez. Dr. Ramirez is dual trained in pediatric dentistry and orthodontics. He holds a PhD in oral biology and 2 master's degrees, one in dental sciences and another in craniofacial pain and sleep disorders. Dr. Ramirez is a world-renowned lecturer and author and has published numerous articles in the dental literature, as well as being author of the book Early Treatment of Malocclusions, Prevention and Interception in the Primary Dentition, co-author of the book The Trainer System, a myofunctional approach to treat malocclusions, and author of the newly released book Pediatric, airway-focused, myofunctional orthodontics. He is especially passionate about the areas of craniofacial growth and development, the pathophysiology of functional disorders in the craniocervical mandibular system, and how the craniofacial structures are modified by functional appliances. Dr. Ramirez maintains a private practice in Aurora, Ontario, and is on faculty in the dental department at the University of Manitoba in Winnipeg, Canada. This is going to be an amazing conversation about growth and development, bone biology, proactive orthodontic treatment, and a holistic approach to patient care that you do not want to miss. Also, please remember to share the show with someone if you think they may enjoy this content, and be sure to follow Doc on YouTube at DeLuke Orthodontic Coaching. If you feel we've earned it, we'd also love to receive a 5-star review on Apple and Spotify. So without further ado, let's get on to today's episode with Dr. Germán Ramirez. Enjoy the show, everybody. Welcome to the Doc Podcast, Germán.
Thank you, Mike. It's great to be with you here. We had the opportunity to meet in person in New York at the planning meeting. That was excellent, sharing some time there.
Yeah.
And yes, it's talking about a little bit of my background. I am a dentist originally from Colombia in South America. Not Colombia, just Colombia. And then it's interesting because when I finished my dental degree, I was thinking, all right, what I should do? I'm going to be a GP, or I want to do a specialty. And I was thinking in doing maxillofacial surgery. And today I think about that, and I was thinking, no, that was not my way. Actually, in my first book, I have a sentence that says, who doesn't have knowledge, cut and throw away. Who has some knowledge, treat. Who has real knowledge, prevent.
I love that. I love that.
So when I was doing my applications, I received a letter from a university in Mexico, and they offered me the program in pediatric dentistry, and I said that would be interesting to work with kids. And it was a kind of challenge for me, and I went to do this program, and I really enjoy working with kids. I don't know why people say that working with kids is difficult. It's difficult to work with the parents, right? To bring the parents on board. But working with the kids, once the kids understand what you are trying to do to help them, they are amazing. They are amazing.
Yep,
So, yeah.
I agree.
So, but when I was doing my program, I was seeing a lot of malocclusions. And I was asking my teachers, all right, what we can do here, for example, an anterior cross bite in a 4-year-old kid, a very deep bite in a 4 or 5 years old kid. And they were saying, no, we are going to wait and we are going to send to the ortho department. And I was saying, but they are going to do nothing at this moment, and what we can do here. So at that moment, there was a transition in the program, and the chair of the department, the new chair, was a little bit in functional appliance. He was working with some of the functional appliances, and he said, Germán, don't argue anymore. Just come here, come to my clinic, and I will teach you. And he started introducing me in functional appliances. So I became interested. So when I finished my program, I was looking for learning more in this area, and I had the opportunity to meet a professor in Brazil, Professor Vilma Simoes. And she was doing real early intervention. And I get in contact with her, and I went to do the ortho training with her in Brazil. But her approach was functional appliance and early intervention. So that was amazing, being with her in this training, and I learned to work with the Planas philosophy. Pedro Planas was a professor in Spain, in Barcelona, and he had this amazing concept of doing the Planas direct tracks. That's why I say all the time Planas direct track, because it's his philosophy, and doing selective grinding to correct malocclusions in primary dentition. And I became very excited that I could start treating kids at 3, 4, 5 years old and not waiting for that. So I started applying that, and I say, all right, but if I am going to work in the mouth, and if I am going to be a real doctor of the mouth, right? Because it's funny, in English, we are saying dentist. So dentist means teeth. In Spanish, we say odontologist. Odontologist means studying the system of the teeth, right? So the system is the mouth. So I said, all right, we need to understand that system. I need to understand that system. And that moved me to Australia, where I have the opportunity to do the first master in oral biology. And when I was doing the master, I started studying the mandibular condylar cartilage, and doing all my research on the mandibular condylar cartilage, because for me it was interesting that people were saying that there was not growth potential in the mandibular condylar cartilage. And I was saying, how I am moving my mandible, and people are saying that I don't have any response in the cartilage here. But when I move my elbow, when I move my knee, the orthopedists, they are saying, yes, you have a response there, and you have to exercise your joint to get a response in the cartilage, right? And to have all the synovial fluids working in a well way. And what is different here? So I went to study that, and I started with animal studies, obviously, and I did all the study, and I understood the mandibular condylar cartilage, and it's a very interesting tissue because the mandibular condylar cartilage is composed by two types of cartilage at the same time, the fibrocartilage and the hyaline cartilage, and both of them are together. And if one of these cartilage is gone, the other one is going to be gone, and then you have osteoarthritis, right? And when I was looking at that, and no, the tissues are there in the animals, so it should be the same in humans. And then later, I have the opportunity to do the research in human. I have a publication showing that you have the mandibular condylar cartilage, the fibrocartilage, and the hyaline cartilage until you are 70, 80, 90 years old. So I had the opportunity to show that there is a growth potential there. The problem is that we need to know how to stimulate that. And then that transitioned me into the PhD, where I did the study in bone biology, and then understanding the two tissues, the cartilage and the bone, that basically is the composition of the maxilla and the mandible. I was saying, all right, we can stimulate growth at any age, but importantly, the best time is the earlier, right? And I was doing that transition. I was saying, all right, do I go for orthodontics, full orthodontics, or I go for pediatric dentistry? And that's when I say, no, I want to start treating kids. I don't want to wait until the problem is totally established, right? And if we look at the literature, if we look at the studies of Dr. Liu on the mandibular growth, we see that the mandible grows over the first 5 years more than over puberty. So if we look at that data, the mandible is growing approximately, increasing the length of the mandible approximately 35 millimeters over the first 5 years. And then later, from 5 years to 16 years, when we have the pubertal sport, the mandible grows, the length increase approximately 31 millimeters. So the mandible is growing more over the first 5 years. And why I'm going to waste that time? And if we look at the maxilla, it's the same. The maxilla is growing more longitudinally over the first 5 years, and then it's a vertical growth. So why I'm going to waste that amazing time? So I say, no, I have to treat the kids. I know to treat the kids early, and I know that they're growing a lot. So why I am going to wait until the child is 7, 8, 10 years old, when the 70-80% of the facial growth is already happened. So I prefer to treat early, right? And then I start doing that. And when I start treating these kids, I saw that a lot of them had sleep and breathing issues. So I started saying, all right, what is the association? So I decided, all right, I'm going to go back to a study. And then I went to my second master, and I went for craniofacial pain and sleep disorders in Tufts University in Boston. And it was funny because they were asking me, okay, Herman, you already have a PhD, you already have another master. Why do you want to come here? And I say, all right, because I want to learn from you, but what I want to learn there, I want to apply in kids, not in adults. So I want to translate that to kids. And that involves me in sleep and breathing disorders issues with kids. That basically is what I am doing today here in Canada, working with children, trying to help them to develop the structural and functional problems so they can have a better airway. And that is something very important that people need to understand. We are dentists. We are not respiratory physicians, right? We are not treating the sleep and breathing disorder. We are treating the structural and functional problems of the mouth. And in that way, as a consequence, the mouth is a part of the airway. We are giving the child a better airway, right?
Thank you. Yes. That is exactly how I explain it. I literally was just in a text thread with a few people a couple days ago, and I said exactly that. We have to get away from this perception that people who think like you and I think that we are treating airway. We have to think about it that we are treating the patient and helping normalize their growth, encouraging them to breathe normally through our part of that. But we are not the physician. We're not going in and treating airway. We are normalizing intraoral and craniofacial anatomy, which is the definition of what orthodontists do. So I don't know why that even becomes a controversial statement. And when that happens, we know the data are very clear that patients with more normal craniofacial and oral anatomy, greater tongue space, broader palates, less vertical growth, broader arches, those patients are more likely to be nasal breathers and have fewer airway problems. So I love that you said that, because to me, I think we almost overcomplicate it by getting too much into the discussion of airway orthodontics or airway dentistry. No, this is orthodontics. This is what it should be, right? This is what we should be doing.
And if we see the history of orthodontics, let's take as an example what Professor Ramirez did. He changed the name of the journal. If you remember, the first name of the journal was Journal of Orthodontics and Surgery. He took out the surgery and he brought dentofacial orthopedics. So orthopedics means the correct position of the dentofacial system, right? So that title is defining what we are doing. We are correcting all the craniofacial problems, and by correcting the craniofacial problems, the patient is receiving health, and health means better breathing, better sleep.
Yes.
Feeling better.
Yes. Yeah. What do you say to people who hear that, because I know this comes from a lot of my colleagues, because they say it to me, and they say there's absolutely no need to treat a patient before the age of 7. There's just no need. There's no benefit. There are no studies that say there's a benefit. What are your answers to that?
One of the problems that we have, basically, I am going to quote a little bit of one of your podcasts with Dr. Price, that he was saying that, and you mentioned this in the panel meeting about the evidence base. The problem with today is that we are saying this is the study, and we are not evaluating our experience, the feelings of the patient. We're not putting all in context. All right, and if we are going to base in studies. One of the problems is when I am doing a research, and I have been doing research for many years, when we are doing a research, we have to answer one question, right? And one of the problems that we have, for example, if I see a patient that is, let's say, 4 years old and have a unilateral posterior crossbite, right? And people are saying, all right, I'm going to treat this unilateral posterior crossbite. We are going to do the research of the advantage of the unilateral posterior crossbite, right? And they are treating the crossbite, but only the crossbite, and they are not considering the other problems that the kid may have. For example, I may have a posterior crossbite that the patient in primary dentition, but the patient doesn't have spaces in primary dentition. So I have a transversal problem as well. I have a posterior crossbite, but a posterior crossbite is associated with a deep bite. So I have a vertical problem as well. I have a posterior crossbite and the patient is showing on one side, the side of the posterior crossbite only, and the maxilla is canted. So I have a coronal problem as well. So when they are doing the study, they say, all right, we corrected the posterior crossbite at 5 years old, but when the patient was 10 years old, we have to do a transverse development. We have to put a palatal expander. Sorry, the problem was there, but you didn't see that problem. So the problem is with your diagnosis, right? Because you didn't. So my explanation is, all right, I have to do a full diagnosis, and not only to treat the crossbite, I have to treat everything. I have to do the transverse development, I have to correct the can, I have to correct the deep bite, and then I'm going to show when the patient is 10, 12, that a minimum percentage need a phase 2 treatment, right? And the literature is saying 50% of the patients that have phase 1 treatment, they don't need phase 2, right? But in my experience in my office, I can say 80% of the patients that has a phase 1, they don't have phase 2. Why? Because when we are evaluating the patient, when we are doing the diagnosis, when the patient is 4 or 5 years old, we are not only looking at that posterior crossbite. We are looking at everything in context. I am analyzing what is happening in all the dimensions, and I analyze in 6 dimensions. I analyze what is the sagittal position of the patient, what is the vertical position of the maxilla and the mandible, what is the transverse problem, what is the coronal rotation, and what is the frontal rotation, and we are doing the functional evaluation. So whenever I am treating a child, I am treating all the problems at the same time, not just one problem. So I am just bringing, as we were talking at the beginning, the craniofacial growth and development to a physiological state. And in that way, we can move forward and the craniofacial growth and development can continue in a physiological situation.
That's so well said. And I love how you put it in perspective of if we only look at one area, and then it's easy to conclude in a study that just treating that area made no significant difference, or you could wait because you could just fix that crossbite a few years down the road. And it's such a great point that part of the problem is you're only looking at the one area and you totally ignored that. So yes, maybe you can fix that crossbite 3 years later, right? If you just look at the teeth, sure. Could you get the teeth to not be in crossbite 3 years later or 4 years later or 30 years later. There are ways, I mean, at that point, you could do it with MARPE or surgery, right? I mean, you can get rid of the crossbite if you're just looking at the crossbite. Well, you could, as you're saying that, I'm thinking to myself, well, then we could make the case, why treat the crossbite at 8? Why not just wait till they're 40? Because you can fix the crossbite at 40. So why don't you, right? I mean, so the argument of starting earlier has no advantage. When you think of it from that perspective, it's pretty much a bit of a bogus argument, because you're, number one, only looking at how you can get the teeth to fit. You are taking a more thorough diagnostic approach, which you've probably heard me talk about with other guests on this show as well. That is something that I think is a big impediment to people even doing this, because you're looking at 6 dimensions. Most people are literally just looking in the mouth. We'll talk about CBCTs in a moment. And they're just looking in the mouth quickly. And they're looking for these indicators of malocclusion, right? Crossbite or maybe crowding. Or they're not looking in 6 dimensions. They're not looking at a 3D patient. And they certainly, you talked about the functional aspect as one of those 6 dimensions. They're certainly not looking at the functional side of these patients. So if you would talk a little bit more about that part of it, the sort of the functional part that you're looking for. What are you looking for from a functional perspective in these young patients?
All right. My first observation is how is the breathing of the patient, right? Because one of the problems that we have today is mouth breathing. And I know that there is a lot of argument that what is mouth breathing? And when we are talking about mouth breathing, people are expecting that the child or the patient is with the mouth open 100% of the time. That is not reality, right? A minimal percentage of patients are with the mouth open all the time, right? But if I see a patient that is sighing, that is yawning all the time when I am talking with the patient, and that brings another point that is important. When I am doing my diagnosis, my evaluation, the patient is not in the dental chair. The patient is talking with me as we are doing right now. We are in front of each other. Mm-hmm. So I can see how the patient is functioning. If I have the patient in the dental chair, I cannot see that, right? So the patient is seated in a normal chair in front of me. And we are talking, and I am seeing it. If I see the patient all the time, I'm very tired. That patient is a mouth breather, even though the patient has the mouth closed. Professor Guillemino used to say, if the patient is with the mouth open 20 or more % of the night, that patient is a mouth breather. And Patrick McKeown is saying, if the patient is with the lips apart more than 30 seconds when he's awake, that patient is a mouth breather. It's a mixed breather, right?
Mixed breather. I like that term, mixed breather. Right.
Exactly, because the patient, yes, the patient is able to breathe through the nose. And the parents normally are saying, no, my child is with the mouth closed most of the time. Oh, yes, when he's watching TV, he's with the mouth open. All right, that is more than 30 seconds during the day. So your child is a mixed breather. So we need to be 100% nasal breather.
Well, yeah, we explain that a little more, because some people will say, well, what's the big deal if they, at Pani, I loved, and I can put links to some of those YouTube videos that you showed in your presentation. They were awesome. What's the big deal about being a mouth breather a little bit of the time? I mean, there are people who would argue that's normal. So what's the problem?
Yeah, and one of the things that I want them to start observing, and is because we need to have a clinical eye, right? One of the things that they may observe in both of us, we are nasal breathers even though we are talking, right? So, and one of the things that you may notice on both of us is that we are not moving our shoulders. When you are talking with a child and you are observing that the child is moving the shoulders. When you are a mouth breather, you are breathing with the superior part of your lungs. So you are breathing in the air and you are bringing the air to the superior part of your lungs, right? And the major blood vessels are on the base of the lungs, not on the superior part of the lung. So if I am using only the superior part of the lungs when I am breathing, yes, I am bringing a lot of air to the mouth, but I am processing a little bit of that air on the superior part. So the change of oxygen going into the blood vessels is less. And then the red cells in the blood are going to carry the oxygen to the cells. So the amount of oxygen that the patient is going to receive, the child is going to receive, is less. So today is a term that is called cellular hypoxia. So every cell in our body is testing the level of oxygen that we have. It's not only the carotid receptors here, it's every cell in our body. And the physiology of our body is going to change. So the cell is going to start producing some cytokines and some substance that they are going to stimulate the kidney, and they are going to stimulate more blood vessels formation, and in order to try to bring more oxygen to the cells, right? Because the cell is hypoxic. And if we know, if the cell doesn't have enough oxygen, the oxygen is the energy for the cells to produce all the good substance that we need for growth and development. So if I have a child that is trying to grow and development with all the appliances that I am putting and all the exercises that we are doing, the cells are not able to respond because they are in cellular hypoxia. So the treatment is not going to respond, right? That was our first goal in function, is to change the mouth breathing to nasal breathing. And that is something that I always try to explain to people, because many people are thinking, all right, I need to bring the tongue up. And that is not the first step. The first step is to permit the patient to open the nose and the patient able to breathe. Because if the patient is trying to bring the tongue up, but the patient is still a mouth breather, the tongue is going to be a blockage. It's going to be a barrier to bring the air in, and the patient is feeling that cannot breathe through the nose, so the tongue is going to come down. So I have to educate the patient first to do nasal breathing, and once the patient is able to breathe better, now the tongue can come up easier, and the patient is able to have the tongue on the roof of the mouth, because the tongue is the best palatal expander. If you think, if you think in the muscles of the tongue, just doing a little analogy, when we are walking, we are using approximately 16 muscles. And when we are moving the tongue, we are using 18 muscles. So you can think about how much force we can produce with the tongue. But the tongue has to be in the correct position. Because what happens when the tongue is going up into the palate, and I position the tongue against the palate, and I'm going to swallow. So the tip of the tongue has to anchor in the area of the incisive papilla, right? When I am anchoring the tongue on that area of the incisive papilla, I am stimulating an AP development of the maxilla. Right? And then the tongue, to move everything to the back for swallowing, the tongue has to anchor on the sides. And that is the transverse muscle. So the transverse muscle has to anchor on the side of the maxilla, and that is going to produce the transverse development. So when I am doing that function with the tongue, I am producing longitudinal development, sagittal development of the maxilla, and transverse development of the maxilla. Then I'm going to breathe through the nose. The flow of the air is going to push the maxilla down. And then I have the vertical development of the maxilla. So in that way, what Professor Erlo described very nicely, the maxilla is growing forward, downward, and transversally.
Enlo described the functional imbalance that occurs when you're not breathing properly. Yeah,
exactly. So in that way, the tongue is producing that. But to bring the tongue to have all that function, we need to have nasal breathing first.
So how do you when you recognize that, are you using CBCT to evaluate the nasal passageways and the turbinates, and then whether yes or no, then when you know that they are struggling to nasal breathe, what are some of the things you do, or how do you work with medical colleagues to get them breathing through their nose?
The image is really relevant because we need to be sure that we don't have a mechanical problem, a mechanical blockage. So that's when all the images, even for example, here in Canada, we are a little bit limited for CVCT. We have to refer to have the full image, we have to refer to a radiologist. But any kind of image, and CVCT is the ideal, right? Can give us an idea if there is a blockage. But one of the things is that we can simplify by, for example, using a mirror, our dental mirror, and to check if there is flow on both sides. Because some patients you can check and one side is totally blocked. So at that moment is when we need to start interacting with the ENTs, with the sleep physician, and saying, all right, this is important that we determine if there is a septum deviation, if the tonsils and adenoids are creating a mechanical block of the passage of the airway. Because if we have a mechanical block, the patient cannot breathe, right? Even though we do all the exercises that we want to do. So we need that, and we need to work as a team. And sometimes it's difficult to communicate, but once you start getting some people, we have been working on that. But once you have somebody in a team with you and they understand what you are trying to do, they will recognize you are making my life easier. So
yes.
So let's move in this direction. I remember a story that is a little bit putting aside. When I was working in Colombia, I became a lecturer and presenting all my work in conference. I was working with babies with cleft palate, right? And what I was doing was, when the baby was born, I was coming to the hospital and taking an alginate impression in the baby mouth. So people always, when people look at me and see me doing frenectomies in babies, they say, is that difficult? I say, no, it's more difficult to take an alginate impression in a cleft palate newborn, right? That is really difficult. So what I was doing, I was doing the traditional treatment is the obturator, right? So the mom the cleft is covered. But what I did was to modify the obturator, and I put like some little bumps at the edge of the cleft, and the cleft was naturally closing. So you may have a cleft of 10 millimeters, and it was reduced to 1 millimeter with this technique. But I have to change the obturator every 2 weeks over the first 3 to 4 months. So when the maxillofacial surgeons and the plastic surgeons that they were doing the surgery, they saw that. They were telling me, hey, Herman, this is amazing. When we go to the surgery, we have just to suture the lip, we have the support of the palate, and we can do the lip at the palate at the same time. So we are saving one surgery. So what was the result of that? When a cleft palate patient was born, all the doctors, the maxillofacial surgeons and the plastic surgeons that were called to the hospital, all of them were saying, we don't touch the patient until Herman treats the patient, because it was easier for them. So it's the same when we start talking with the doctors and we start showing them. I know sometimes the physicians and the specialists, they're going to say, I'm too busy. What do you have to teach to me? I went to talk with the group of the sleep physicians here in Ontario, and they were happy when they saw what I can do with the kids with the appliances. And they were saying, oh, Herman, I will refer to you. And today we know that a CPAP machine should be the last resource in a child, because it's producing a head tear effect. It's pushing backward. And they recognize that. If you talk with a sleep physician, they say, yes, I know that I may affect the craniofacial growth and development of the child, but I don't have any other results, right?
Right, I need to breathe.
Yes.
Right.
And I need the patient to breathe, right? And they are totally right. But when we show them, all right, if I develop everything probably you are going to feel better. If you give me the opportunity to work a little bit and I correct that structural problem and that functional problem, you are going to work easy with the patient. And I have a couple of sleep physicians, a couple of pediatricians that they are totally on board today, and they are saying, "All right, can you do something first before we go more aggressive with this child?" So we have to start educating them, right? Yes, and the only is to try to go and communicate and continue doing what you are doing, communicating and spreading the word, so we can work better.
Yeah, it's so well said. And I found that once I educated, it was a reciprocal education. My allergy colleagues, ENT colleagues, I was on the cleft craniofacial team at the hospital for many years. And it was actually a lot of those providers that I started to learn how to read cone beams from, how to understand the otolaryngological side of things and the surgical side of things. And that collaboration is so huge. And once you find those people and you start to find people who are like-minded, and then, as you very well said, they would say to me, "You make my life so much easier." Or the ENT would say, "Now when I see somebody who has like moderate obstruction of their adenoids, because of what I've learned from you, I'm looking in their mouth. I'm trying to see, do they have a high vaulted palate? Do they have narrow V-shaped arches? Do they have crowding of their teeth?" So when this 6-year-old kid comes into me because of the fact they're worried that they have adenoidal hypertrophy, and the ENT looks in there and says, "Geez, I don't know if this warrants surgery. They're not that obstructive." They now look, and instead of having to send this parent away or put them on maybe Singulair or something or a nasal spray, trying something because they just don't know what to do, they say, "Go see Dr. DeLuke, and I think there's a need for him to help your son or daughter grow better." And we know from Audrey Yoon's paper in Sleep Medicine in 2022, and I saw this in my patients all the time. I actually showed an example of it at PANI, that when we go in and help these patients grow better, the vast majority of the time for these moderately enlarged and hypertrophied adenoids, they shrink when the patient starts nasal breathing. And you showed it beautifully in your schematic as to why.
And if you understand the reasoning for that, the tonsils and adenoids is a lymphoid tissue. If you attack the lymphoid tissue, the lymphoid tissue overreacts. It's a defensive tissue, right? So I always use the analogy, it's an army waiting there to see what is going to happen at the border, and then, all right, they're attacking us, we need more soldiers here, and the tissue is overgrown. All right, the attack is over, I can remove the soldiers here, right? So that is the normal reaction of the lymphoid tissue, so it makes sense. And if we start talking with the physician, with the pediatricians, with the ENT in this way, but we have to show them some reasoning that makes sense. Right? And one of the things that I explain to them is, all right, if you look at the literature, the relapse after the surgery with tonsils and adenoids is high, right? So the literature is showing that.
Yeah, the Bhattacharya study in 2010 was over 70%.
Yes. So 12 months, the child starts snoring again, and there is an overgrowth again. Why? Because the airways blockage was removed, but the child continued breathing through the mouth. Nobody explained to the child.
Yes.
They are expecting, now it's open, the child can breathe through the nose automatically. That doesn't happen. Now it's a habit. Right? And what happens when you have a habit in your brain? It's like a writing there, and what you are doing is overwriting that habit. Okay, so you have a bad habit and you create a new habit that is good, right? But the old habit is here. So let's say the child was a mouth breather, and now I open the airway, and the child saying, "Oh, I can breathe through the nose." So the child starts creating a new habit and override the old habit. And the patient is saying over the first months, 2-3 months, "Oh, I can breathe through my nose." But then 3 months later, the patient had a flu and the nose became totally stuffy. The old habit override the new one, and the patient come back to mouth breathing. So that is something that we have to check. And even with the patients, we are treating the patients. We have been a patient 1 year nasal breather, then a seasonal allergy. The patient became stuffy.
Yes.
And then the patient become back to mouth breathing. We have to go back to the exercises of breathing and to retrain the patient again, because that habit, the whole habit is still there. We never get rid of the whole habit. They are always there waiting for the opportunity to come back. So that's very important. And when we explain to them in this way, and we say, all right, yes, you did the surgery is successful, but to maintain the results, we need to see the patient, because let's say the patient has a narrow palate. We need to make a better shape of the maxilla. And in that way, the patient is going to be able to breathe to the nose and put the tongue on the roof of the mouth, and the results of your treatment are going to be stable, and probably you will have a high incidence of relapse. And they may start thinking, oh, that makes sense, right? So why not to collaborate? So, but we have to go with arguments. It's not I refer this patient because you have to remove the tonsils and adenoids. No. Or your surgery failed because the patient is, again, having a second stage because you have to remove again some tissue, right? No, I can make your results, I can help you to make your results more stable because this, and we explain in a scientific reasoning way, right? And they're gonna be happy.
And that's why I get so frustrated with the studies that talk about looking at expansion versus adenotonsillectomy. I literally, and then they'll take it a step further and talk about relative to AHI in a child. And if you really understand sleep and airway and breathing and sleep disordered breathing in the pediatric population, you know that AHI is a very poor barometer of that. Guimeno talked about that extensively, and it's all over the medical literature. I mean, the child can have severe sleep disordered breathing and not register with an AHI of 1 or greater on a sleep study, and there's many, many reasons for that. The second part of that is to isolate these modalities into monotherapies and compare adenotonsillectomy versus expansion is really almost a fool's errand, because you oftentimes will need both. And as you so well said, okay, so they remove the lymphoid tissue, but the patient still has a narrow arch. They still have insufficient tongue space. They still have the habit of being a mouth breather. You hear from parents all the time, they got their tonsils and or adenoids out, and it maybe got better for a little bit. They weren't snoring as loudly, which again, there's less tissue to reverberate, so that makes sense. But there's still, their mouth is open. And, over the past few months, I'm noticing that I'm starting to hear them snore more. They're louder breathers when they sleep again, or they're getting tired. They're harder to wake up again in the morning. They were doing a little better for a little bit of time. And that doesn't mean that adenotonsillectomy doesn't help the situation, just like if you have only the transverse correction of the width, and then you say, well, expansion doesn't help airway. It's not isolated into silos. We are not isolated into single parts of our craniofacial complex. It's all connected. Right?
And that's the problem. And we go back to today, everybody's asking for evidence and asking for studies. And the problem for the studies is that you can answer only one question at a time.
Right. Just as you said before.
Right. That's the problem of the studies. So they're answering one question, but they are not seeing the full context. All right, I do a palatal expansion and it's not improving because the patient continue mouth breathing, right? Nobody corrected it.
Yes.
And that's why I don't like when people say, no, this is the gold standard. Sorry, but the gold standard is just treating one problem, and you are losing the perspective. And that's why, for me, it's very important. And you were mentioning AHI, and Professor Guillemino, over his last years of life, he always say that was a big mistake from me. I shouldn't propose that, because it's basing everything in a number. And we are diagnosing the patient based in a number. Right? And he was explaining that I can have an AHI of 1 in a child, but the child is sleeping for 10 hours. So the 10 apneas can happen in 1 minute, right? And that is going to kill the patient. But the AHI is showing me 1, right? And that is not reliable. And today the studies to show a result, they have to base in the AHI. So asking for evidence that we know that evidence is based in something that is not 100% reliable.
Completely. And anytime I see a study in children that bases the outcome on AHI, or I talk with a colleague who bases it on AHI, I essentially know that colleague doesn't understand the pathophysiology of sleep disordered breathing and the spectrum of disease that is sleep disordered breathing, with snoring on one end as the most mild and OSA on the other end as the most severe. And so many studies are out there in the medical literature talking about children who suffer from obstructive hypoventilation, which is not going to result in these complete apneas and hypopneas of 10 or more seconds duration or for 2 successive breaths, but are still tremendously consequential for the health and well-being of these kiddos. I mean, I honestly think, Herman, I don't think most of our colleagues even know that. Would you agree?
I totally agree, because I see a lot of children that they go for a sleep test and then the doctor say, no, your child is normal because your child doesn't have OSA. Right. But what happened? What happened with the snoring? What happened with the restless sleep? What happened with the grinding the teeth? What happened with all these symptoms that are showing that the child is having a problem, right? And that's why I like the guidelines of the American Association of ENTs that was published in 2019, that they are saying sleep disordered breathing is another entity in that spectrum, and we need to look for that. And those kids, they need treatment as well. Don't wait until they are fully diagnosed as an OSA child. And if we look, the number of child, the percentage of child with OSA is very low. But the percentage of of children telling us my child is snoring, my child is grinding the teeth, my child is with the mouth open when sleeping is huge. It's almost every patient coming to our office. How many patients, if dentists start looking at how many patients they are struggling to treat the child because the child is a gagger. When the child is gagging, it's because he's trying to breathe through the mouth, because the child is a mouth breather, and the dentist is blocking the mouth now for the child to breathe. So it's a defensive mechanism. So every gagger, every bruxer.
Talk about the bruxing for a second, because that's something I think a lot of people maybe have heard, but they don't understand that, if you don't mind. What is the relationship between the bruxism and the airway?
Listen, let's start thinking in this perspective. Let's think in a patient that is bruxing the teeth. Normally, a bruxer is a deep bite. Normally, when you have an open bite, the parents don't report grinding the teeth. But if you look at the patient that is grinding the teeth, they are a deep bite, right? So think about a deep bite, and where is the room of the tongue? The room of the tongue, the space of the tongue of the mouth has been reduced because the height of the mouth has been reduced. So now I have the mouth closed. The front of the mouth, there is no way for the tongue to go there. So the tongue has to go to the back. And when the tongue is moving to the back, the tongue is coming down and moving to the back, the tongue is blocking the oropharynx. So the volume of the oropharynx is reduced because the anterior wall of the oropharynx is the base of the tongue. So the volume of the oropharynx is reduced and the patient starts feeling like choking. So the brain starts saying, hey, tongue, you are blocking the airway. Move forward. But the tongue has no space to go to the front. So now the tongue has to recruit the stronger muscles, the tongue protruders, right? And start pushing the mandible, but the mouth is closed. So the mandible starts moving forward, but the teeth are together. You have two surfaces that they are sliding together. That creates friction. And when you create friction between two surfaces, you produce a noise that is grinding the teeth. The tongue is pushing the mandible, trying to open the airway. So that's the explanation of what is happening. And the studies are showing that just the grinding is occurring at the same time with the respiratory effort. So when the child is trying to breathe, the tongue is pushing the mandible forward, and that friction between the teeth is producing the noise that is tooth grinding. So that is the association between them.
And I learned, I think most people still learn that, oh, well, it's normal that they'll grind when they're in the primary dentition. It's soothing.
It's only one time that is normal, the tooth grinding. When the baby is around 1 year old, that the baby gets the incisors, but the molars, the first molars have not erupted. The mandible was free to move forward and backward. And actually, that's the movement over the first months that we want for breastfeeding. The mandible was totally free to move forward and backwards to stimulate the endochondral ossification on the mandibular condylar cartilage. So when we got the incisors, now the mandible has a stop. So the child start grinding a little bit the front teeth because it's recognizing that stop. Then the first molars come, and then everything is stabilized, and the grinding should be over. That's the only moment that I accept tooth grinding. Then when the patient is reporting tooth grinding, I have to check for an airway problem. Something in the structure of the mouth, something in the function of the mouth is going to produce that grinding.
Yeah, it's such great information. And I have a lot of laypersons that listen to the show as well. And I don't think most people know. We just don't learn this. Everything pretty much that you and I have been talking about to this point are things that I didn't learn in my training. And I went to very good schools, as did you. You obviously pursued more of it in your postdoc training. But I think it's really important for everybody to understand that may be, and I've said this often, that maybe where a lot of the resistance to what we're talking about comes in is it's not familiar to people, number one. Change is hard, number two. If you've never thought like this or treated younger kids or been more proactive in your approach, and you've spent your whole education and whatever part of your career trying to just be the best tooth straightener you can be, right? Orthodontist trying to straighten teeth. It's really hard to think about it. Do you agree? I mean, I guess, what are your thoughts on why there is so much resistance to this, especially from our establishment, AAO, our academic institutions? They just seem to not want to support this concept that we're talking about.
There is a paper in the American Journal of Orthodontics and Craniofacial Orthopedics in 2015 by Professor Ackerman. And Professor Ackerman is saying the problem is that we are technologically driven and not biologically driven. That is one of the problems. If you see, when we go to our training, you have to do 10 crowns, you have to do 3 root canals, you have to do this amount of period, you have to do this amount of extractions. So we are learning techniques, but we don't understand why. And for example, when I was teaching at the university, I had the opportunity, I was the head of anatomy. And I was going to the clinic to see the students in the anatomy was in first year, and then the students in the third and fourth year, all right? And when for example, they were delivering the LA to numb the patient, they were doing the mandibular block, and then we were starting to work on the tooth, and the patient was jumping. And I said, what nerve are you missing? And they look at me, and I say, oh, you are coming with the anatomy question. I say, yes, you have to apply the anatomy in the clinic, right? You are blocking the mandibular nerve, but you forgot to block the buccal nerve. When you put the injection at the back, you are blocking the mandibular nerve, but you are not blocking the lateral one coming from behind on the superior part before the mandibular is coming on the buccal side. So the patient is receiving intervention there. So if you don't apply your anatomy, your clinic is not going to be successful. And the problem that there is no connection. When we are learning, there is no connection between the basic sciences and the clinic. And in the clinic, we are reviewing and doing the technical part, but we are not remembering the basic science to bring to the clinic. And that's when these become two islands, that's when we are excellent doing techniques. We are logically driven, but we forget the biological part. And that's why I said at the beginning, I want to know the system, how the system works to understand all of this. And when we enter into the concept of guiding craniofacial growth and development, that is why I talk today about myofunctional orthodontics, or working, because I need to integrate the orthodontics with the functional part and the muscles, because it's a very basic concepts in bone growth and cartilage growth. I need to create tension in the tissue. And the only way for me to create tension is with the muscles. So if I want to develop craniofacial growth and development, I need to know how to work with the muscles.
And what do you say to people who say that there are many in our profession who say that you are genetically programmed to grow to a certain way, and it's all genetics, and there's no influence of environment? What is your answer?
Right.
I know what I say, but I'd love to hear your thoughts.
I like that question, because I say, all right, so if it's genetically driven, can you tell me what is the gene producing the distal occlusion? Because if you are saying it's genetics, it means that there is one gene involved that is causing these problems, right? Whenever we describe any disease, any problem in the humans that we say is genetics, we are saying it's because there is a defect in this gene. Or that's what we talk today about epigenetics, right?
Yes.
It's a marriage. Whoever was saying that it's genetics is 50% right. Whoever is saying it's functional is 50% right. You have to put both of them together, right? Because with the function, I am sending a message to the cell, and the cell is going to produce the substance accordingly to that message, right? So in that way, I can modify the genetic response. I don't modify, nobody can change the genes, but we can modify the genetic response. So when I have a stimulus from the environment to the cell is gonna say, all right, I'm not gonna produce cytokine A, I need to produce cytokine B. And then receive another stimulus, and the cell is going to say, now I need to produce cytokine C, and shoot down the B and the A. And in that way, we are changing the genetic expression through the environment. That is the way that it works in our body. And people say, but look at here, I have the mom who need braces because the teeth were crooked, and the child is going to need braces, right? So it's the same. It's because the mom. I always joke with the parents, and when the mom tell me, "Oh, I had a similar problem," I say, "No, it could not be from you. It is from that." And the mom always look at me. Why do you say that? And I say, because good things are always from mom, bad things are always from dad. So in that way, I start getting the parents on board. And I enjoy that. But I say, all right, you have braces because you have a problem. Yes, a malocclusion, but your child is going to need a treatment, but it's another problem, right? And I look, for example, when I have an anterior crossbite, I look at the parents and I look at them, and they don't have an anterior crossbite. So I say, all right, what is the relationship here? Is the child, something happened, there was a dental interference or something that started creating another information, and the expression went in another direction, right? And also, for example, Professor Corrucini, he mentioned that, all right, who is our hero? My hero was my dad, or my hero is my mom, or my hero is my older brother. If my dad is walking and spitting every 5 minutes, I'm going to mimic exactly the same behavior. Right? If my dad was a class 3 and my dad used to bite like this, I'm going to mimic my dad and I'm going to bite like my dad. So I am mimicking, I am repeating a same pattern, and I am creating a similar genetic expression, right?
And we know that environment in every other part of our body, as you were just referencing, plays a significant role. Our diet can change the way our genes are expressed. I mean, we don't debate this even psychologists, the diathesis stress hypothesis, they call it, where you have your genetic makeup, but your environment and your influences, especially in childhood, can impact the way your genes are expressed. Why would we think that this craniofacial complex is completely removed from every other part of our biology? I can't understand why very intelligent, very well-read people would try to make that assertion.
Yeah, and what happened, the other thing that I explained is we have a genetic windows, right? For example, in our body, our height, our stature. Let's say I'm going to be something between 6.5 feet to 7 feet tall, or let's say meters, so I'm going to be between 165 to 175. That is my window, right? So if I am a child that I grow and I am sitting in front of the screen, just playing video games, my mom is putting the food here beside me, and I don't move, I don't exercise, I'm going to grow. But I'm going to become 165, right? But if I am a child and I am going out, playing basketball, playing soccer, playing tennis, playing a lot of sports, being very active, I'm going to become 175. So that is my window, and my genetic expression is going to be there. The same happened here. My maxilla can be about 25 millimeters to 40 millimeters. If I have a good diet, if I chew hard food, if I have my tongue on the roof of the mouth, I'm going to be 40 millimeters, not 45, right? But if I breathe to my mouth, if I never put the tongue, if I am in a soft diet, my maxilla is going to be 25, right? So we have that window, and I need to stimulate to bring to the maximum of the window. And that's why some people ask me, but if you put a functional appliance and you overstimulate, you're going to have a very wide maxilla. No, never is going to happen. Because I have that window. I have that genetic information that is going to limit. All right? Now I have the maximum. Now I'm going to maintain this. And that's the idea for this patient. Right? Right? And then when I have enough room for the tongue to stay in the mouth, not overlapping, not overcovering the teeth, when the swallow is happening in a correct position, when the breathing is going through the nose. So I am in the maximum of my window. Now I need to maintain this, so this is maintained. And our body has the capacity, again, that if I remove that stimulus and I go to the bad habit again, that is going to shrink. If you remember, let's put an example. If you remember your dad, when at some point you were looking at your dad and you were saying, my dad is taller than me, right? And then you grew up and you say, oh, I am at the same height of my dad. And you maintain that height. But suddenly your dad starts shrinking. And now your dad is, why my dad is smaller than me? Because now your dad is not as active as used to be, and the body starts removing tissue because we don't need that amount of tissue. So the same happened here. If I stimulate everything and the tongue comes to the roof of the mouth, and I stay on the roof of the mouth and we are doing the swallowing corrected, and we are moving everything around, the maxilla is going to maintain that size. But then something happened and I became a mouth breather again, and my tongue came down. And it was for a while. The maxilla started shrinking. I started having problems again. So that is something that we need to maintain that function. It's like with our body. It's exactly, and we need the muscles creating tension on the bone everywhere. If you start going to the gym today, and then you are going to see 6 months later, and let's say you are lift weighting, right? Doing a lot of workout, you are going to see that your arms are bigger. But if you measure the bone inside, the change is minimal. But if you continue for 5 years, your bone is going to grow. Because the muscle
and be more
is going
dense.
to be more dense. Exactly. So that happens here. If I increase the stimulus by the muscles here, my bones are going to grow. And I need to maintain that stimulus for the bone, but I need time. And that is another argument that I tell the people when we are evaluating growth development. We are measuring the bone. We are not measuring the muscles, right? So what happened? I put a functional appliance in the mouth to stimulate growth and development, right? And let's say the mandible comes to the front. I reduce the overjet, let's say in 18 months. If I measure in a ceph the length of the mandible at the beginning and 18 months later, it's exactly the same mandible. The length of the mandible is not significantly longer, right? But clinically, I am seeing the mandible here at the front. So who did the change? The muscles are holding the mandible in a new position. So what I need to do is to measure the activity of the muscles to see if there is any change. So the muscles are now stronger and are able to maintain the mandible in a different position. So later, if I follow the patient 5-10 years longer, then I may see a change in the size of the mandible because I need time for the bone to respond, right? And many of the studies that I'm saying you cannot stimulate growth and development, they are measuring between 1 to 2 years. At that moment, you are not seeing. We did a study with electromyography, and we are showing that the activity of the muscles, we have patients with normal occlusions, we have patients with a retruded mandible. And we showed that the patients that we did the treatment, the activity of the masseter and of the suprahyoid muscles were the same as the patients that has normal occlusions. And the patients that we didn't do any treatment, the activity was very low. It didn't change with the growth. So we need to understand that relationship between the muscle and the bone to understand growth and development.
And this gets into, as you were referencing with Corricini, and a lot of the anthropological data, which if we're not stimulating these muscles young, because a lot of people just hear a harder diet, and how does that really help you grow? But what you're explaining extremely articulately is that muscle stimulation that you do from a very, very young age is going to then guide the growth of the bone. And I love the analogy you used with exercise and fitness. I mean, no one debates that building muscle mass stimulates bone development and bone strength, right? I mean, osteopenia, loss of bone strength and density as you age. One of the ways to combat that is greater muscle mass and prevent sarcopenia and prevent the loss of muscle. So we know the bone biology, the physiology, we understand that. It doesn't seem to me like a big stretch to say, well, when you're a young child, and you are first developing these muscles, if you're eating a soft, processed, purified diet and you're never developing the muscles, then you are not going to stimulate the bone growth. And I mean, Corricini, who's been published, it's so funny when you said about not connecting that we're technicians. I so agree. We learn the didactics, we learn the anatomy, we learn the physiology, we learn it to the highest extent. And then we go into the clinical setting and it's like we forget it all. I mean, in my residency, we read Coracini, we read Harvold, we read all of that. We read about the functional matrix theory, we read about Enloe and his growth hypotheses. Yet we go to the patient and we're like, oh, got to straighten teeth. You know, I'm a tooth straightener, I straighten teeth. There's this disconnect. Yeah, I agree.
It's totally disconnected. And talking about the diet, nature is showing us perfectly. When we are born, we need a liquid diet. We don't have teeth to process, right? Mm-hmm. And we need to stimulate the mandibular growth, and we need to educate the tongue to be in the right position through breastfeeding. Then we get the incisors, so we start cutting little pieces, right? And then we can move to a soft diet. Then we get the molars, and we can harden the diet a little bit more because now we can destroy something more. And most likely the last one are the canines that now we can guide to go to the side to destroy harder food. So we have that transition from birth until we are 2 to 3 years old, that we move from a liquid diet into a soft diet and then into a more fibrous diet, right? And for example, when I see a patient with a deep bite, I tell the parents, he loves pasta. He loves, whenever you do a barbecue, you have to do a hamburger for him or a sausage, right? He doesn't like any green leaf. He doesn't like any piece of meat that he has to chew a lot. And the parents look at me and say, how do you know that? I say, because he cannot process that food. When you have a deep bite, you cannot do lateral excursions, and you cannot process any harder foods. So they stay in a soft diet. And when you stay in a soft diet, you are not developing the muscles. You are not activating the muscles, and the mandible and the maxilla are not going to respond. I'm going to stay in the minimum of that window. Not going to grow. It's the minimum for surviving. Right. And that's it.
Yeah. Yeah, you have a great line too that you said when you spoke about what you tell the parents. It's great to see how you obviously have an amazing ability to analogize and relate a lot of these concepts, not just to your colleagues, but to your patients and patient families, which is a real skill and gift. What is one of the things you say to them about the function of the nose versus the mouth?
The nose is for breathing, the mouth is for eating. Yeah, that is, and that always make the kids laugh and to understand why they need to breathe through the nose. Because normally I say, all right, do you put food here? And they say, no. So why do you put air? As you're pointing to your nose. Why do you put air here? So the air should flow here and the food should come here. And immediately in the brain, any child, 3, 4 years old, is going to understand that. And now they understand why they need to breathe through the nose, right? Yeah, it's simple. I think that has a skill as a pediatric dentist, I think, because in pediatric dentistry, we learn how to speak, and we have to speak with the child with very simple words, right? And I always tell to the people, who is your patient? Your patient are not the parents, your patient is the child. So you have to speak with the child, and the child needs to understand what you want to do and why you need to do that. If the child doesn't understand, the child is not going to collaborate at all. And if you explain to the child in very simple words like that, the nose is for breathing and the mouth is for eating, and you make that funny analogy, the parents are going to understand very simple as well, because they are not dentists.
Yes.
If I say to the child and the parents, your child has a distal occlusion, has a deep bite, I am speaking in Spanish. They don't understand what I am saying, right? If I grab, and that's another thing that I have. We were talking before that whenever I am evaluating the patient, we are talking in front of each other, right? The child is in front of me, sitting in a chair, not in the dental chair. And the other thing is that I have all the records with me. I have the x-rays, I have the scan, I have the photos with me in the computer, so I can show the child. And instead of saying, I have a deep bite, I grab the 3D image and I rotate the digital models, and I say, look, you are biting almost on the palate. So sometimes, do you feel that something is irritating you here? And the child say yes. I say yes, because your teeth are biting on behind here. So the child immediately understands why we need to increase the vertical dimension. So now the child has the idea, I need to avoid going that deep. So if you put something here in between, my bite is not going to be that deep, and here is not going to be irritated. So you are going to help me. Yes, I'm going to help you. All right. Now the child is going to accept what I'm going to do. Right?
Yes. Yes. And I think that I use that interestingly, the exact same approach for those deep bite patients. And I think, and I'd like to hear your thoughts, my opinion, and I've said this a couple times, we're not, as orthodontists, not only are we not trained, and hearing you speak, your ability to relate to these younger children and your behavior management techniques, being that you have the pediatric dentistry background, gives you such an advantage in that. As orthodontists in our training, most orthodontic residents graduate never treating a patient under the age of 7. And even that, in the age of, say, 7 to 10, they may treat 1 or 2 in a lot of orthodontic programs. So as much as we oftentimes, and fairly so, will say they're not getting trained in treating these patients, they're not getting trained in the behavior management of these patients. And I think that's a big obstacle. What do you think?
It's huge. It's huge because the success of the treatment is based in a good communication with your patient. Right?
Right.
And again, your patient is the child. And your communication has to be with the child, not with the parents. And when you are able to present everything in very simple words to the child, the parents understand perfectly what you want to do. You don't need to explain.
And I think they appreciate it. I find they appreciate that you talk to the child. I had a lot of parents that would say it was great, or even if after I left the room, that they would mention to my treatment coordinator, it was great that Dr. Mike actually related to my son or talked to my son. They're not used to that. Most places they go, the pediatrician, or not to knock on them, but they're not really relating to the child necessarily. They're doing an examination, they're looking at things, and then they're updating mom and dad. So it's really a great subtlety, but it's not so subtle when you do it. It seems subtle. We'll talk to the child, but most of us do. We walk in the room, and I always had a little trick. I would walk in and I would introduce myself to the patient first. If it was a child, I'd go to the patient and I'd say, hey, I'm Dr. Mike. Nice to meet you, and shake their hand or fist bump them based on what they were comfortable with. And then I would turn to the parent or parents and say, hi, Mike DeLuke. Nice to meet you. After I introduced myself to the child, because as you said, they're there for the child. Yes, they're the caregivers and caretakers and going to be responsible for the decisions. I need to relate to that kid. I need that child to trust me.
Exactly. You need to, even I have seen a baby they're bringing a newborn for a tongue tie evaluation or something like that. I go to the room and I start playing with the baby. I don't look at the parents yet. I start playing with the baby and how you're, are we going to have a good fight today? Are you going to let me see at your mouth? I start making tickles to the babies or checking the reflex on the foot. And then I say to the parents, hey, how are you doing? What problems are you having, mom, with the breastfeeding? And then I start chatting with them. Because when you approach, and always think as a parent, right? I always think, I always explain to my colleagues, whenever you are seeing a patient, is your own child. Think about your own child. What do you want for your own child? And if you come to any doctor, you want that doctor to be nice with your child. Right. Immediately you are going to trust that doctor. If the doctor is nice with your child. Right. If the doctor is giving all the importance that the child deserves, you are going to be very happy as a parent. So do the same with your patients. That's the trick.
Yeah. This has been an awesome conversation. You are just a wealth of information. I loved hearing you speak in person when we were at PANI, and getting to know you and hearing you share your wisdom. I think what makes it most impressive, Herman, is that you have the ability, you have a tremendous amount of knowledge of the biology, the physiology, the literature, the anatomy, And you also have tremendous clinical experience and acumen, and you can do this, and you do this with your patients and have amazing personal skills to relate to it. And that makes you unique.
Thank you.
That is not super common to see that. So I'm not surprised. I had heard amazing things about you before I've gotten to know you in the recent months here. And I'm not surprised as I've gotten to know you more, just how impressive you are in all these areas. And I'm not just saying that. It's not super common. What I hope people can find, though, is see how possible it is to do what you do, and to realize that what you're doing is all backed up. You are evidence-based practice, as I talked about in my talk at PANI, right? You are embodying evidence-based practice. You're taking the clinical experience that you have and your clinical expertise. You're taking the research and data and the sort of quote unquote science, and you're taking the patient and parents' values and perceptions and desires into account. And where those three intersect is evidence basis. You are the essence of it. So I can't thank you enough for what you do, but for taking the time to also educate others. You could just be doing it on your own. You don't have to take the time and energy to teach it. So I really just want to acknowledge you for that. Really, really great.
Thank you. No, that's what I like, and I love teaching. Whoever is interested in learning a little bit more, we have a mini residence here in Toronto. We are planning with Dr. Steve Lambert to bring it to PANI in New York, and probably to develop it in some places in the United States, to bring the mini residencies so people can learn what I do. As you said, if I can do it, everybody can do it. It's a model of getting into it and to be motivated to give health to the patient, because if that is our goal, we are a health professional. So our goal is to give health to the patient. And the only way to give health to the patients is to understanding the biology of the body and how we can correct the problems that are affecting that physiological stage of the patient. And that's the only way. Yeah.
Yeah. Well, I appreciate it so much. How can people get in touch with you if they want to reach you? I'll put a link to your new book too, which is awesome, on the show notes. But anything else?
The book is available. The book is available in Amazon. It's a pediatric airway-focused myofunctional orthodontics. We have a website that they can contact us, kidsmalocclusions.com. We put all the information about the courses and all the information there. My first book is available there, the book that I published in 2009. Now, obviously, that there is a lot of more information in the new one that was released this year. But they can contact me through that website. There is an email, contact@kidsmalocclusions.com. So anything that they may need, I will be available. I try to respond as quick as I can. Sometimes I am busy, I cannot respond very quick, but yes, we're trying to bring this information closer to everybody. If you don't want to fly to Canada, so hopefully we will have this mini residence also in the US soon. We are planning with another group in England, the Untitled Society, to bring the course also to UK. I'm going to be in Singapore in September, giving the course for Asia. So I'm trying to move as the time permits me, trying to move. I'm going to be lecturing for another group in Dallas in October. So I'm trying to move around the world, trying to spread the word, and trying to teach all the colleagues. I am open. Whoever wants to learn, I am happy to help and teach.
Well, that's evident. And that's been one of the most fun parts for me in doing this, has been getting to meet colleagues such as yourself and really help me learn and see things from a different perspective as well. You're an amazing educator. I can't thank you enough for
everyone, and I am open to continue learning. So I am a professional student. I like to learn from everybody. Everybody has something to teach. So I like to listen to people and to learn from everybody. And thank you, Mike, for hosting me here, to sharing with me. It was very interesting. The time flies. Has been
I know.
almost an hour and a half now, and the time flies. No, it was amazing. Thank you very much.
Yeah, I agree. I did not realize when I looked down that it would have been that long because I was so enjoying it. So, well, thanks so much. Dr. Herman Ramirez, you are an absolute asset to our profession, and I thank you for coming on and sharing what you do with the audience.
It's a pleasure. It's a pleasure, and always open to collaborate. Thank you.
Awesome. All right. Thanks. Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.